keep connecting. He should be there. There he is. Good morning. Hello, hello. Can you hear me?
Good morning. Good morning. Sorry,
Yeah.
I had a bit of a technical glitch, but thank you. Thank you for bearing with me.
Not a problem. Could you hear us while we were there? So I was just quickly running through who you were. So let me do that again. This is the wonderful Vikram Talaulikar from the Menopause Clinic London, who is a gynaecologist and specialist in menopause. And there's very few people who know as much about it as he does, plus also early menopause, which is something that we will touch on as we go through this. So let's get right into this now. I'm a little book of notes here, so if I'm looking down, that's what I'm looking at. Now, I've run through about 20 of the symptoms. Of course, there are many, many more of them. So how do we know, with all of these symptoms that range literally from dry skin and brittle nails and hair falling out to mind problems and stress incontinence, how do we know whether or not they are actually related to menopause?
So that really is more dependent on the age and the pattern of how the symptoms have evolved. So as you rightly said, there are more than 30 to 35 symptoms which have been associated with menopause. Some of them are classical, like hot flushes or night sweats. Some of them are unusual, things such as itching of skin or sometimes feeling very much anxious in places or circumstances that you would not usually be anxious. But all that is important to be putting into perspective against the woman's age and what her hormone pattern at the moment is. So anybody who is of the age beyond 40 years of age, who's experienced a bit of irregularity of periods, some of the symptoms which I described, it's usually menopause, unless you can explain a cluster of symptoms because of some other medical reason. Mm-hmm. So I see a lot of patients in my clinic who will come and say, I don't know whether this is just menopause or I have got a lot of stress at work, a lot of stress at home. Is it just the stress? How do I differentiate? And one of the ways is to say, have you noticed any other things which are happening along with some of your symptoms, your periods, your overall energy, any other hormone symptoms? And you look at the age, look at the cluster of symptoms, and you often say this is more than likely to be menopause. The reason I'm kind of hopping on this is because there's a temptation to do blood tests, but that's the last thing you want to do, because often the blood test won't change so early. It's crucial thing is how the woman feels. And sometimes then doing a trial of hormones helps. It's a lot more of a diagnostic rather than therapeutic option. But I guess we'll come to that a little bit later.
Yeah, it's an interesting one because it is, you see that offered a lot, and let me sort of slightly divert you a minute, especially for things for bioidentical hormone treatments. There are a lot of people who say, well, I don't want to take HRT. I'd rather do something natural. I'll do bioidenticals. What do you think about that?
So when you look at HRT, so you're trying to address hormone-related symptoms. So what we want to really give the body is the estrogen, which is the key hormone, because that estrogen takes care of all the symptoms, protects against the bone loss, the heart disease, etc., etc. So you want to give the body which is as close to what the body would naturally produce. Now, there are two terms we need to understand. One of them is body-identical hormone, and the other one is bioidentical hormone. Bioidentical hormones are combinations of different estrogens or progesterone. Sometimes some of them are not usually the ones which are used in the conventional HRT. These combinations of estrogen progesterone are usually dispensed by individual clinics who do bioidentical HRT. They're quite effective. So many women find that their symptoms disappear, they feel well, they have some health benefits. The difficulty, though, is we don't know about the long-term safety of these medications, simply because they haven't been put through a rigorous randomized trial as some of the conventional HRT. It's called bioidentical because it comes from plants, and usually it's wild yams. That's the most common source of hormones. And then they are usually put in different combinations. If you compare that to what is body-identical HRT,
which is what is in the new types of HRT, isn't it?
That's right. So body-identical HRT is the one that's now used by most menopause clinics which do regulated HRT or standard HRT. This is like for like estrogen, progesterone. Again, this comes from plant source. Usually it's wild yams again. But these are usually something called 17-beta estradiol. That's a particular estrogen. That's like for like what your body would normally produce. And similarly, you've got the natural progesterone, which would be similar to the one that ovary would produce. These have been rigorously studied for last 1 or 2 decades. And we know what can happen if somebody takes these hormones in the long term, whether it's 5 years, 10 years or more. And we know that they are safe to use. They represent body's own hormones very closely. So the bottom line is, if you're using bioidentical, they may be effective. They're usually unregulated. So we don't know about the long-term safety aspect. If you're doing body identical, which are regulated HRTs with menopause clinics, same as the body's own hormones, but you're much better there in using these because we know about the safety profile in the long term. And body identical hormones are much, much better than any of the synthetic old HRTs we used in the past.
Yeah, and I think the important thing in that is the unregulated bit, isn't it? So you've got compounding pharmacies. So you have a blood test. On that particular day, they'll tell you you're either up or too low on this. They'll make a compound supposedly for you, but that blood shot is a snapshot in time, isn't it? So it may not necessarily be what you'll be in an hour or so. Yeah. And also, once it's compounded, you don't know whether there's nobody looking at that compound to make sure that it is exactly what it says it is. And I think there was a study done in the US a while back that found that only about 19% of the compounds that they tested actually contained what they said they did. So, yeah. You're looking at a lot.
That is not useful at all. Your hormone levels on a day-to-day basis will differ based on how hydrated you are, what is the time you took the medication, how well you're absorbing it from the skin or from the gut if you take it through the skin or orally. And there are so many factors which will make your hormone levels vary throughout the day. So doing a snapshot of bloods and then actually giving you something that's meant to correct it, it's not completely scientifically valid.
No. So let's talk about HRT for a minute, because there's still, as we know, every so often articles come out that say, my God, the risk is dreadful. And then there's a big backlash from people like you who are menopause experts and say, well, hang on a second, those articles are based on old drugs and data from long going studies that involve drugs that we are no longer using. So what do we know about the ones that we are actually using now, and are they safe?
Okay, so most of the scare about HRT stems from the studies which were published around 2001 to 3, and the biggest one of them was the biggest randomized trial, which was Women's Health Initiative from the US. The drugs that were used in that trial are no longer being used in modern HRT. So the first thing is we cannot compare what we are giving today to some of those results, because the drugs which were used were synthetic. The estrogen that was used was horse-based, and this is no longer being used in the UK. But even if we consider the findings of the trial to be important, then what the trials actually showed was that taking a combined estrogen-progesterone HRT for 5 or 10 or more years would increase 2 significant risks. One of them is blood clot and stroke or heart event. The other one was breast cancer. Now, over the years, we've now realized that the modern HRT doesn't compare to this, because the type of progesterone we now use, the one we mentioned before, body identical, that actually is much, much safer than the synthetic progestogen, which was used in the study. And the natural progesterone is much more breast safe than the synthetic progestogen. There are still other ways of giving HRT today. For example, giving progesterone as a coil, which is another fantastic way of giving it, because you're limiting the amount of absorption of progesterone in the blood. Similarly, with the blood clotting, the HRT that was used in the big study that gave all the bad name to it was oral. And now we know that if you give somebody HRT, particularly estrogen as a patch or a gel, then it does not increase your risk of blood clotting unless you are predisposed to have it because of a medical condition. That's different. But for most healthy women, it will have no increase in blood clotting or stroke. So the difference is the current HRT just doesn't compare to the old ones. And then if you're using the current HRT, the next question is, what about the recent papers which actually had a little bit of these HRTs and still said breast cancer was a risk? So if you remember, there was an article in Lancet. This was last year, I think around September, October. It was a big observational analysis of more than 100,000 women who'd received HRT over the years. And it still said breast cancer is a genuine one. Now, there's no debate that if you take combined HRT over 5-10 years or more, there is a slight increase in risk of breast cancer. That risk is very, very tiny. So something like 10 in 1,000, depending on what kind of combination you're on. And for most women I see in my clinic, they will say, I don't care. The kind of quality of life I experience and the benefits for bone, for heart, for my mood, for energy, I just have so many other risk factors in my life which are far more important for breast cancer than the pill or the patches I'm taking. So it's individual decision for a woman to say, is that tiny, tiny increase in risk of 10 in 1,000 something that she would not like to accept and not take HRT, or are the benefits far in excess of that tiny risk? Yeah. And again, the other thing is, if you take...
Sorry, keep going.
If you take estrogen alone, then that risk doesn't exist. So we now know that if you look at observational versus randomized studies are gold standard scientific studies as compared to observational. And the recent randomized study data does show that estrogen alone does not increase the risk of breast cancer. In fact, you will be surprised to know in the results it showed a reduction in breast cancer. So to say, if you're taking estrogen, progesterone, tiny increase in risk, but if you take it as a coil or the body identical progesterone, even that risk is really, really can be minimized.
Yeah. And to put that into perspective, though, the risk from being overweight, drinking alcohol, and not exercising is actually greater than HRT.
Absolutely.
Yeah.
Obesity and smoking are the two big issues there. These two are the big problems for the breast cancer risk. Yeah.
Yeah, I think people are quite surprised when they see that, actually, because they the chart I think that you guys at the Menopause Clinic had before with all of it sort of nicely laid out in cases per 1,000, and when you saw the alcohol, the obesity, the exercise, it was almost I think obesity was almost like double the risk from memory. And I think you see these sort of women go, oh, I'm not going to take that. It's not, but I have a friend, rather overweight, does no exercise, drinks quite a lot, smokes, won't take HRT, and you sit there thinking, okay. Yeah, it's so when it comes to the benefits of HRT, you did touch on a couple of those before. What would be the reasons? What do we know about what it does in terms of benefits?
Yeah, so the first obvious one is the symptoms. Whether you've got the classical symptoms, it's hot flushes, night sweats, they will disappear if you have a good HRT. You have the other symptoms, the mood, the energy, the libido, the vaginal dryness, the bladder infections, you've got sleep difficulties, insomnia, and a few others. So all those symptoms should really disappear as long as you get a good dose of estrogen. Once you've got the symptoms out of the way, then there are long-term health benefits. And we're really talking about the two proven ones. That's the bone health and the cardiovascular health. So we know that if a woman takes HRT between 50 to 60, I'm just taking a random duration of 10 years, then there's a massive improvement in bone density. So it will prevent osteoporosis or osteopenia for sure. But it's very good for heart. So you reduce the amount of heart disease after 60 years of age. And if you took HRT longer, then of course that benefit will be higher. Yeah. One other benefit which now coming to light is the effect on the brain. Now this is an unsettled issue. But we know that if somebody starts taking estrogen early in their life, when they are perimenopausal and having some symptoms and irregular periods, it does seem to provide some protection against cognitive decline. So that's the risk of long-term risk of developing dementia. Now, there have been some studies which combined progesterone with estrogen and thought maybe the risk is higher if you take HRT. So that issue hasn't been completely settled, and we are awaiting some more bigger trials in that particular field. But it does look like if you give early estrogen, it does prevent cognitive decline and accumulation of some proteins in brain, which would contribute to dementia. So watch that space.
All right, so you've got Alzheimer's as well as just vascular dementia. All right, because those proteins are associated with Alzheimer's,
It's mainly the Alzheimer's, yes.
Oh, good. That's good to know since it runs in my family. The other thing I was going to say on that, so we've got your bones. Nobody talks about bones. So we have a the menopause test on Harley Street Emporium, and a few hundred people have taken that, and not a single person has mentioned bones, which is kind of sad. Nobody thinks about them. But the thing that they often do mention, and you touched on it before, was depression and anxiety. And probably, I would say, around 60% of the women who've taken the test now are on antidepressants. I think only one was taking HRT, but yet they all claim to still have the mood problems of depression and anxiety. So what's gone wrong there?
Get everybody off antidepressants. Give them HRT. I'm just joking. So I think antidepressants are overused. It's not that they don't have a role, but we know that usually feelings of low mood or depression peak around the perimenopausal age. The rate of suicide does go up around this age group as well. All that means that there are so many life factors which influence somebody's mood, and perimenopause, of course, doesn't help, or menopause doesn't help with all these symptoms happening. Often the first line to treat mood symptoms during this period is the GP will often give you an antidepressant. That's because...
Which is not surprising. I mean, if you turn up saying, I'm tired, I can't sleep, I'm stressed all the time, I feel unhappy, I don't like my life, you could see exactly why that would be the first thing you'd think.
Yeah. But the problem is you're not treating the cause, because for most of the women that present this way, it is the lack of estrogen that's causing their brain to act in a particular way. So replenishing estrogen back in the body immediately usually takes care of these symptoms. So for example, when I see patients in my clinic, I'll often say, if you're on antidepressant, don't stop. Start taking a little bit of estrogen back into your body, and they often notice that they have some benefit that they did not see when they started using the antidepressant. So over a period of time, what we can do is you go up the HRT and you slowly wean and come off the antidepressant. Now, I'm not saying that antidepressants are not absolutely useful or they're useless for everybody. That's not the case. There'll be a proportion of women where HRT is not actually the only solution. There are other factors other than hormones. And so it's very important to kind of differentiate or distinguish between these. As you keep seeing the patient in your clinic, it becomes obvious this is not all down to hormones. But for majority of women still, it is definitely HRT that will take care of the problem.
Now, we've got a question here, which is actually a good one, so I'm going to come back to this in a minute. How do you know if you can just take estrogen alone, or whether or not you need to take progesterone also, please? Also, is breast cancer increased if you have breast implants?
No. So with the implants, there is no worry. It's the same rule would apply to you if you had an implant. It's the breast tissue that's surrounding the implant. That's really the one that's get affected. So the risk would be similar. I wouldn't put any increased risk if you have an implant. You need progesterone if you have a womb, if you have a uterus. That's because if you take estrogen alone, it thickens the lining of the womb. And if you persistently have a thick lining of the womb for a long period of time, a year or two or more, then it can develop into something we call as hyperplasia, which is unhealthy lining. And that itself can predispose to cancer in 5 or 10 years' time. So you can eliminate that risk of cancer by taking progesterone, which is why you take progesterone if you have a uterus. If you've had a hysterectomy, uterus has been removed, then you don't need a progesterone. This is again the other point to make is the progesterone therefore only serves to protect the lining of the womb. It doesn't really do a lot for other symptoms. A little bit, but not a lot. You want to keep that hormone minimum as much as possible and take the best one, which is why taking body identical progesterone for the minimum length of time or the coil is the best solution.
Okay, that's a very good answer. That's good. It saves me going back to that one, so I don't have to remember that. Where were we? Oh, so what I was going to actually ask after that as well was, okay, if you don't want to or you can't take estrogen because of a history of breast cancer or something in your family, then what are your choices?
Well, first of all, if you've got history of breast cancer in the family, that alone is not enough to say you can't take HRT. So what would be important to find out, is it genetic? Do you have a gene that's actually predisposing you to have higher risk of breast cancer? For example, we know about a few genes, the BRCA1, the BRCA2, and few others. So if you've not got a gene, and if your gene testing is negative, just purely based on the history, I wouldn't deny somebody HRT. It really is a question of how much benefit can HRT have for that particular individual versus the risk of developing breast cancer. And so I've had plenty of women who've had a discussion in the clinic to say, yes, I know my baseline risk may be higher because XYZ individuals in my family have had a breast cancer, but my tests so far have been negative, and therefore I would still like to consider HRT because I can't live like this. I can't live with so many symptoms, a poor quality of life, and I would more than likely support the decision to commence and stay on HRT for these women. All you would want to then make sure is that you cut down other risk factors. So you know that you're taking HRT, that's helping you. You try to cut down if you're smoking, try to maintain a healthy BMI, try to give up alcohol if you're drinking too much, etc., etc. So that the only real risk factor then is your HRT. But in no way, I would say you can't take HRT. You can definitely take HRT.
Yeah, there's one question here that actually relates to one of the questions that came in before. If you take otogestin vaginally, do you use 100 milligrams every night or every other night? Which also comes back to one of the questions that I had, which was the woman who said, I've used pessaries, they annoyed me, they irritated. I'm now using the cream, that's irritating me, and I'm bleeding as well. What next? So we're going sort of moving around here a little bit, but this is a little bit of... Yeah,
so let's go to the first question, which is about the progesterone. So progesterone can be taken. If somebody is taking progesterone cyclically, that's usually 12 days or 14 days of the month, and that's likely to get them a bleed every month, then that sort of progesterone can be taken as oral or can be taken vaginally. So far, whatever medical evidence we have is all good for the oral progesterone, which means taking it by mouth or having a coil of progesterone. Now, some women can't tolerate oral progesterone, which is why they are often prescribed vaginal progesterone. The slight difficulty is that many of the studies have not shown that the vaginally administered progesterone is good enough to protect the lining of the womb in the long term.
Okay.
So if somebody uses, say, 12 days or 14 days of the pessaries vaginally, that's usually Cyclogest or other vaginal progesterone pessaries, the worry is, over a period of time, it may not be sufficient progesterone to make the lining of the womb thin for a long period of time. So we have had occasional patients come back with thick womb lining or polyps where we've had to then stop them taking this particular HRT and give them different form of progesterone. So if you can tolerate and if you can take it, I would always say avoid taking progesterone vaginally. Try to take it orally or as a coil or as a part of a patch. That's completely fine. Now, if you have to take it vaginally and you're okay with monitoring and avoiding this risk of having thick lining by having scans every 3 months or 6 months, making sure your womb lining is not thickening, then the ideal dose would be something like 200 milligrams for 12 days vaginally. So every day. You can't take gaps on progesterone. If you take a gap, you'll often have a tiny bleed and your lining is not being protected. So 12 to 14 days.
You'd end up doing this, wouldn't you?
Correct. So 12 to 14 days continuous progesterone and vaginally is okay. But if you notice any irregular bleeding, it's not working. It's best to take it orally, patch, or a coil.
Okie dokie. All right. So if you can't take estrogen at all, just going back to that, what options are there? Are we talking supplements? Are we talking... Where do you go? What do you do to get these horrendous symptoms under control?
Okay, just before I answer that, I think I skipped your second question about the Augustine and irritation with the...
That's all right. I'll come back to genital urinary symptoms in a moment.
And so with the supplements, so if somebody doesn't want to use hormones, what options have they got? So they've got non-hormonal medications, which I guess we can discuss later if you have time. But you've got the supplements, herbal therapies, alternative therapies, which are non-medical intervention. Trouble is, not many of them are terribly effective. And I'll be honest here, I've got nothing against herbal treatments or alternative therapies or supplements. They do help in certain controlling certain symptoms. But as a treatment long term, they're not terribly effective. And sometimes you can end up spending significant amounts of money trying to take one supplement, another supplement, one after the other, and then eventually come back to using HRT, which just stops everything in the go. But if you were to use, of course, you've got herbal treatments. Some of the popular ones are the black cohosh, the red clover, and you've got the menopause, which combines a few of these herbal remedies. I've had occasional patients who felt better on it. They had less flushes, less sweats, felt less anxiety. But most patients have come back saying it's not effective. They don't do much harm, and most of them are pretty inert and estrogen-like compounds. However, there have been occasional case reports where a sensitive individual has developed problems with liver, which is why we often don't recommend it as part of our clinical treatment, because you don't know which patient will be sensitive enough for these particular herbal medication that they develop complications with liver. So the best is stay away from them. Try to use HRT rather. But if you're really not wanting to take HRT, then you can always give one of these combinations a try.
True.
If it works
No,
for
that's
you,
true. It is
great.
a much
If it
cheaper
doesn't
lifestyle.
work, then you will have to look for another option. With supplements, the two important crucial ones are vitamin D. And if you've got any tendency of blood clotting in the past, then that's folic acid. Those two are really, really key, vitamin D and folic acid. Women who've had bleeding issues, gynae issues in the past, also iron, because we
Austria
often
or
find
Romania as
the
well.
low energy comes not just from lack of estrogen, but they also have low iron, which then keeps
And
contributing
how much you have to spend
low
in Austria
energy.
or Romania?
So iron, vitamin D, folic acid, those three are really crucial. There's a recent paper or some evidence saying magnesium helps.
Okay,
And
and how
so
much does it
all
cost
of
for
those would
Romania
be
or
the ones
Austria?
to look for. Other than that,
Yeah.
whether you take B6, B complex, people take different forms, combinations. There's no robust evidence that it helps everybody, but worth a try. You're not going to damage yourself by trying these supplements.
Yeah, the magnesium, that's an interesting, because we had a couple of questions on that, magnesium and insomnia and magnesium and anxiety. Evidence on that it helps either one of those in particular?
Magnesium, some recent evidence is there to say it helps with neuronal function, gastrointestinal function, and so people have noticed that magnesium in good quantities does help with things like anxiety, sleep, flushes, and overall feeling of better energy. Again, there is lack of robust randomized studies, but I think these will happen because now that we are realizing magnesium helps, these studies will take place in due course of time, and they may show some obvious benefits. But you can't go too much wrong with magnesium. You can't really overdose because kidneys usually filter it out in the urine quickly. So as long as you're taking a reasonable amount, something like 300 to 500 a day, then it'll either do something good for you, but in 3 months' time, if you don't notice anything, then stop the magnesium.
Yeah. We have the same person here asking a question. Just let me preface this for a second. Obviously, you can't give medical advice specifically here. You can only give general medical advice. So the lady saying, I mean, you did mention you've got to take it every day continuously, going back to the progesterone. And she said she can't tolerate it by mouth. But you mentioned that you're having no periods, which is so I'm kind of a little bit confused about that. So what would you suggest on that? Do you maybe change it to a patch or the coil?
Yes.
That's gone down.
So it's, is the lady taking it cyclically or every day of the month? Does she mention that in the?
She'll have to come back and answer that, I guess. So let's move on from it, and we'll wait for her to come back. But it looks like she's taking it every second day, from what I can gather. Another one here. I can't have HRT because of a cancer history. I have terrible hot flushes. What can I do? Now this is where some of the antidepressants might come in handy, perhaps.
Yes. So medical things to try would be the venlafaxine, which is an antidepressant, to be honest with you. But out of the ones that we often have as an option to prescribe, venlafaxine seems to be the most effective against hot flushes. It's usually taken as 75 milligrams once or twice a day. For many women, they notice better sleep, less flushing, mood is better. You've also got a drug called clonidine, which I personally don't like, I'll be honest with you. It's an anti-blood pressure medication. Again, helps by acting on part of the brain that triggers flushes. But it causes a lot of dizziness during daytime and can cause episodes of low blood pressure, giddiness. So I don't often prescribe clonidine in my practice. But those two are the medical options.
Cyprus, Malta, or
There's another one called anti-epileptic called gabapentin. Again, drowsiness is one of the major issues with gabapentin. You've got a sort of non-medical option, which is part of, again, doing the herbal treatments or something called alternative therapies. So I run a clinic for breast cancer patients at UCLH who've had chemotherapy and so of course can't take HRT. Some of them have found alternative therapies very useful. So these are like acupuncture,
Like acupuncture or?
homeopathy. Combination of a few things, a few of the herbal treatments along with acupuncture, acupressure, and then of course you've got the homeopathic medicine. Now again, I'm not an expert.
Only 3 million, New Zealand.
But let's say if I send 10 women a month for these particular therapies, at least 3 or 4 out of 10 say their problems are solved. They can have a reasonable quality of life without having to choose to take hormones. So that's something that doesn't work for everybody, but a very good option.
Okay, well, that's interesting. That's good to know. Now, moving on, because a lot of people seem to think that, okay, the average age of menopause is 51. After that, it's all clear sailing and you just breeze off into your old age happily. Now, I can personally tell you that this is not the case. Some of these symptoms do tend to sneak. Oh, they sneak up on you. Things, I mean, despite being a medical writer for nearly 30 years, I had absolutely no idea of what was coming when it came to vaginal atrophy. It just slowly came along, and it can be devastating on your relationship, your sex life, a whole bunch of those sorts of things. It just does not stop at 51. So in terms of that, what can be done? Which actually comes back to the pessaries and the creams again.
So vaginal dryness happens because of lack of estrogen. And we see often a discordance in the sense that women may have systemic symptoms. They may have hot flushes, mood changes, energy, but no vaginal dryness. And some women may purely have vaginal symptoms and have no systemic symptoms. We don't know why that happens. It's probably individual tissue sensitivity. And some women will, of course, have both. The best option for vaginal symptoms is of course the estrogen replacement, either as a pessary. You get tiny 10 microgram tablets called Vegifem, which are used twice a week. Initially, you start using every day. After 2 weeks, you do it twice a week. If somebody doesn't like to insert a pessary, they've got creams. So you've got Ovestin cream, which can be inserted vaginally. If these cause irritation or symptoms, as the question that was asked to you, there's a new product which is called as Intrarosa. Intrarosa is actually a hormone called DHEA. It's a precursor of some of the other hormones like testosterone. And it's quite useful because I have had patients who have not tolerated estrogen vaginally, but actually gone on to like the pessary, which is Intrarosa, DHEA, and it's available for prescription. Again, doesn't have any major systemic side effects like the vaginal estrogen. It's pretty much very safe. For women who just wouldn't want to insert any tablets vaginally, you've now got ospamifene, which is an oral medication. It's basically an estrogen receptor modulator, which can be taken orally. And that again is very good for vaginal atrophy symptoms when you don't want to use a pessary. It's again pretty safe. There's not a lot of data in terms of if you've had breast cancer in the past, but for most other women, it's quite safe.
Yeah,
and I must point out that for women with breast cancer history who've had treatment, vaginal estrogens are safe. So if you're suffering from vaginal atrophy symptoms, please do not worry about using vaginal estrogen. They do not get absorbed significantly in the blood. So you can improve your quality of life massively without worrying about whether I would get my cancer back. No, please don't suffer. Take vaginal estrogen even if you've had breast cancer.
Maddie?
Yeah.
No.
Excellent. All right. Moving on. The other big thing is weight gain and menopause. A lot of people complain about this, suddenly getting fat around the middle. And then we see a whole bunch of these things called hormone-type diets suddenly appearing. What are these? Do they work? And what can you actually do about weight gain as you move into menopause?
So weight gain is a problem. It's actually counted as one of the symptoms of menopause, and rightly so, because there are so many changes happening in the body, all contributing to weight gain. So the metabolism slows down, the tolerance towards digesting sugars goes down, insulin resistance goes up with age, and of course the collagen in the skin and the skin tone decreases. So all that contributes to weight gain around the middle.
Oh, good girl. Hop. Good, good. Give it to me. Give it to me. Give it to me. Give it to me. Give it to me.